Hi, my name is Abed Dandashi. I'm a clinical nurse educator. I graduated in Lebanon in 2003 in Orthodox institution. And our topic today, we will talk about the assessment and care of adults at risk of suicidal ideation and behavior. First, we'll start about talking about the background about our case. Every year in Canada, approximately 4,000 people die by suicide. Suicide remains a leading cause of men, women, and young people. According to the Mood Disorder Society of Canada, suicide accounts for 24% of all deaths among Canadian ages 15 to 24 years. 16% of all deaths for the age group to 24 up to 44-year-old, and the age range between the highest number of suicides is the age group of 25 to 44 years. Suicide is a complex phenomenon that is influenced by physical, psychological, spiritual, social, economic, historical, political, cultural, and environmental factors. Many people in Canada have been affected by suicide at some point in their lives by its family members, peers, colleagues, or friends. In every family and in each community, the aftermath of a death by suicide is a painful and tragic as it's profound and far-reaching. Now we'll talk about some practice recommendations that the nurse should have when she will receive a patient who has a risk of suicide. First, talking seriously. The nurse should talk seriously about all statements made by the client that indicates, first, directly or indirectly, a wish to die by suicide, and or all available information that indicates a risk of suicide. Number two, all verbal and non-verbal behaviors that may convey an expression of dying and taken seriously. The client is assessed for suicide risk. And here's some suggestion that you may ask, or the nurse may ask the patient who has or he or she is suicidal. You are thinking about ending your life? Are you suicidal? Do you have a plan to take your own life? Do thought of death, of suicide enter your mind? This some sample of questions that might the nurse knows and ask the patient. Number four, the nurse should assess and document and communicated the appropriate members of the health care team. Based upon the assessment, appropriate interventions are initiated. Number two, therapeutic relationship. The nurse works toward establishing a therapeutic relationship with the clients at risk of suicidal ideation and behaviors. The therapeutic relationship describes an interpersonal process that occurs between the nurse and the client, which is purposeful and directed and advancing the client's best interest and outcome. The qualities of the therapeutic relationship include active listening, trust, respect, empathy, and responding to the client concern. Number three, reduce stigma of the patient. The nurse works with the client to minimize the feelings of the shame, guilt, and stigma that might be associated with suicidality, mental illness, and addiction. And she should also minimize the effect of the nurse's own potentially negative reactions of the client. It is essential that the nurse engage in reflective practice and obtain support to address such challenges. Number three, cultural safety. The nurse provide care in keeping with the principle of cultural safety, cultural competences. Both the client and the nurse bring their own culturally derived attitudes values, and beliefs to the therapeutic relationship. As such, culture can greatly impact how issues of mental health, suicide, and death are discussed and addressed in the context of the relationship. The nurse should demonstrate acceptance and respect for the culture of the client and for associated differences. In addition to advocating for change in response to policies and practices that may be experienced as unsafe by the client. Physical safety. The nurse assesses and manages factors that may impact the physical safety of both the client and the interdisciplinary team. The nurse needs to ensure client own safety before intervening to enhance his or her safety. This may involve enlisting the help of others, such as team members, police, and or emergency services, or even leaving the scenes until appropriate support are in place. The nurse should be alert to the physical setting and any item in it that may pose threat to safety. Reduce access by removing such item from the person and the environment, be it the hospital room and or the home as appropriate. External stimuli such as noise and commotion may increase agitation and aggression. In such cases, reducing the cause of stimuli or moving to a less stressful area may be helpful. In some cases, the client may present with physical injury that requires medical attention. Life-threatening injuries should be addressed immediately. The acuity of other injuries should not be underestimated and should be considered when prioritizing the client's care needs. Ongoing medical and physical assessment is warranted in such cases. Maintaining the client's dignity is essential. Considerations of emotional and psychological safety should be balanced with ensuring physical safety. Hazardous items. There are some items that should be removed from the room of the patient totally. And these items, it might include clothing like a belt or shoelaces, cords, lighter, linen, medications, oxygen therapy devices and tubing, plastic bags, sharp or glass objects, toxic substances. Risk factor. The nurse recognizes key indicators that put an individual at risk for suicidal behavior, even in the absence of expressed suicidality. For individuals who exhibit risk indicators, the nurse conducts and documents an assessment of suicidal ideation and plan. Even in the absence of expressed suicidality, the nurse's knowledge of risk factors may help to identify individuals with suicidal ideation and behavior. Risk factors include those characteristics that have been studied in large populations and have been shown to be associated with an increased likelihood of suicide. Risk factors include those characteristics that have been studied in large population and have been shown to be associated with an increased likelihood of suicide. Demographic or social factors. Being an older adult, maybe being a male, poverty that might lead to suicide, being aboriginal, especially youth ages between 14 or 24-year-old. There are some cases like gay, lesbian, or bisexual orientation, association with attempts. They didn't like their life and they want to suicide. Being single, social isolation, economic or occupational stress, new incarceration, history of gambling, easy access to firearms. Clinical factors. Fact and current major psychiatric illness, including bipolar, schizophrenia, and major depressive disorder, especially depression. personality disorder like borderline and antisocial, impulsive or violent traits by history, current medical illness, family history of suicide, previous suicide attempts or other self-injuries or impulsive acts, current anger, agitation or constricted preoccupation, current abuse of alcohol or drugs, easy access to lethal toxins including prescribed medications, formulated plan, preparation for death or suicidal note, childhood trauma like sexual abuse, physical abuse, suicidal ideas, current or previous, suicidal intent, severe or unremitting anxiety, panic attack, and aggression. We have some protective factors. We have to talk about it now. Protective factors defines as aspect of a person's life that give them some reward, meaning or sense of purpose or sense of connection with others. Protective factors are associated with a decreased risk for suicidal ideation and behavior, and therefore play a major part in both risk assessment and supportive care planning. Moreover, a positive therapeutic relationship has also been suggested to be protective against suicidal behaviors. There are now some protective factors, we will talk about it, including intact social support, active religious affiliation or faith, marriage and presence of dependent children, ongoing supportive relationship with a caregiver, positive therapeutic relationship, absence or depression or substance abuse, access to medical and mental health resources and impulse control, proven problem solving and coping skills, pregnancy, life satisfaction, relief about no completing suicide, sense of unfinished business, good self-esteem and self-confidence, awareness of significant others about their suicidal thought and sense of belonging. Now we will talk about some warning signs that the nurse should take care about it. The following information may be reported or be observed by the client and or the family member, friends, community support, medical records, or mental health professional. First, talking about suicide or death directly. Talking about suicide or death indirectly, including themes of hopelessness or worthlessness. For example, what's the point of going on? I'm tired. Everyone would be better without me. Threatening suicide, describing method of suicide or researching methods of suicide on the internet. Formation of suicide plan. Increased intensity of suicide ideation. Putting affairs in order, for example, making or changing a will, giving money or possessions away, donation one of his body to the science, saying goodbye, or writing a suicide note. Purchasing or stockpiling medication, firearms, razors, exploring balconies, bridges, and rooftops. Engaging in risky behavior like increased use of alcohol or substances, reckless driving, self-neglect, like change in appearance, including changes in weight and appetite. Change in personality, change in mood, like depression, anxiety, and agitation. Social withdrawal and isolation, including a loss of enjoyment in activities. If the nurse suspects a risk of suicidal ideation and behavior, the further assessment of the suicidal ideation and plan is required. First, presenting problem and or current mental status, history of present illness, past psychiatric history, past medical or surgical history, current and recent past medication, drug allergies, substance use history, forensic history, family history, psychological history, and nursing diagnosis. We have some questions. It helps the nurse to ask the patient who has planned to suicide when he will be arriving to her clinic. Like, how has your mood been lately? Has anything been troubling or worrying you? Have you had time when you have been feeling sad or down? Have you ever felt like life is just getting on top of you? Do you sometimes wish you could just make it all stop, or that you could be just the end? Have you thought about how you might do this? Have you ever wished you were dead? Have you ever thought about taking your life seriously? Sometimes people feel that life is not worth living. Can you tell me how you feel about your own life? What are some of the aspects of your life that make it worth living? What are some of the aspects of your life that may make you feel or think that your life is not worth living? Do you find yourself wishing for a permanent escape from life? How would that happen for you? What might you do to achieve that? Clinical interview. To conduct a comprehensive assessment regarding suicidal ideation and plan a clinical interview, and use of a valid and reliable assessment tools may be used to gather information specific to presence of risk factors, lack of presence of protective factor like future orientation, cultural and or spiritual factors, suicidal intent, plan, lethality, access to means, time frame, hope, and previous attempts. Suicide assessment tools. SAD person scale. SAD, it contains 4 points. The SAD person scale for assessing the risk of suicide: sex, age, depression, previous attempts, ethanol abuse, social support lacking, organized plan, no spouse, sickness. All of this point, we can talk about it in one word, and it is SAD person scale. Here is the form that might the nurse use it to assess the patient who have a suicide risk. We will talk about some point like presence, influence of hopelessness, recent stressful life event, like if we have number 3 for the first point, 1 for the second point, we will just do the total, and when we will have the total of the risk, we can know if the patient is in high risk, low risk, or medium risk of suicide. We have 4 levels of engagement: level of risk and corresponding suggested level of engagement, score of 5 or less, low level of risk estimated, which suggested level of engagement number 4, score between 6 and 8, intermediate level of risk, suggested level of engagement level 3, score between 9 and 11, it's a high level of risk, suggested level of engagement level 2, score of 12 or more, very high level of risk, suggested level of engagement level 1. Level of engagement, level 4, which is, if we see it here, low level or risk estimated. It's engagement of a structured daily basis. Once per day, it's enough to assess the patient. Level 3, formal engagement at least 3 times a day, morning, afternoon, and evening. And this the point, it is a score between 6 and 8. Level 2, regular support, approximately every 15 minutes, varying between 10 to 20 minutes from the nursing team throughout the day or night. So it is totally, during the day, we should assess the patient and reassess him every 15 minutes. Level 1, this is the very high, the very high level of risk, constant access to a nurse or other professional for support. So 24 hours we should be assessing the patient and watching him. Here is the observation levels. Level 1, we do a general observation. The location of all patients should be known to the staff and at all the time, but not all patients need to be kept within sight. Level number 2, Intermittent observation. The patient's location must be checked every 15 minutes. This level is appropriate when patients are potentially but not immediately at risk. Level number 3, within eyesight. This is required when the patient could at any time make an attempt to harm themselves or the others. The patient should be kept within a sight at all time, by day and by night. We should assessing the patient. Level number 4, within arm's length. Patients at highest level of risk of harming themselves or other may be need to be nursed in close proximity at all the time, including when the patient goes into the toilet and the bathroom. There are some stuff, the debriefing strategies, we will talk about it now. In the organization that does offer the debriefing for staff involved in the care of a client who has stopped suicide, the nurse can ensure any or all the following are provided. Use should be made of existing traumatic incident response plans. Consideration should be given to bringing in an external consultant with expertise and experience in leading a response to suicide death. Staff should be provided with information about the specific suicide death and about suicide generally. Existing risk management procedures should be implemented to minimize risk of suicidal behavior among staff, patients, and others. Effective assessment procedures should be used to identify those at risk or severe grief responses at a risk of suicidal behavior. A meeting between staff and the bereaved family should be offered, and a facilitator provided. A review of circumstances of the suicide should be conducted. Individual staff should be provided with access to professional supervision. At the end of the intervention of all staff involved should be debriefed and the traumatic incident response plan revised as needed. And a message from me to you: you live only one time, so don't finish it with suicide.